everyone, it's Dr. Tofi. Hi everyone, it's Dr. Tofi. Welcome to HerniaTalk Live. I'm here with you every Tuesday. My name is Dr. Shirin Tofi. I am your hernia and laparoscopic surgery specialist. For those of you joining me on Facebook at Dr. Tofi, thank you as a Facebook Live. Also, many of you are here via Zoom. As you know, at the end of this and with all my previous episodes, you can watch it and share it on my YouTube channel, from my YouTube channel at HerniaTalk. And also, thank you for those that follow me on Twitter and HerniaTalk. We had a lot of Twitter activity this past week as I was at a conference. So thank you for those of you who followed me there. So I'm very excited because I have a great colleague of mine from Texas, Dr. Gabriel Arevalo. He is a hernia and gastrointestinal surgery specialist. He comes from out of Houston, Texas. You can follow him on Facebook at Dr. Arevalo. And please say thank you and hello to Gabriel. Hi.
Hello, everyone. And thank you for hosting me, Dr. Tofe. Very excited of talking about this very, very common topic.
Yes.
Very common problem to have.
You're very passionate about it because even before we started live, we were still talking about hernias and so on. So many people get hernias, and I always joke because when I go on Instagram, the only thing I look for are people's hernias, like their belly button hernias, especially. Especially nowadays, everyone's wearing like midriff bearing outfits on Instagram. So it's kind of become a hobby of mine. And so now people actually DM me and text me pictures of belly button hernias they see on a movie or on some type of social media post.
You notice it, the one on Shakira.
Yes. Yes. Super Bowl. Yeah.
Yes.
So she has a diastasis with a hernia, which is probably why it looked more. Yeah. Because she's had what? I think 2 or 3 kids now. I don't know.
I think it's 2 kids.
More than, yeah, at least 2 kids. It seems like the diastasis kicks in after not so much for the first pregnancy, but definitely 2 or more pregnancies, and you start getting the diastasis.
The muscle separation there.
Yeah. So maybe tell our audience a little bit about your practice. You're in Houston. You do general surgery. You're mostly GI and hernia surgery, robotic surgery, laparoscopic surgery. You have extra training in that. So maybe tell everyone a little bit about yourself.
So my practice is located in Houston, Texas.
Yeah.
And here we have a hernia center as well, as part of Houston Methodist, where I practice. I do mostly all my surgeries through tiny incisions, either robotic or laparoscopic. That is my to-go technique, because I can offer them something that not many surgeons are able to offer here.
Yes.
Is that faster recovery, that less pain. And my passion is hernias. That's the most common. I will say if I have 10 surgeries in a week, 8 will be hernias. 1 will be a gallbladder, and another one will be a little lump that I need to drain.
Did you know you like hernia surgery from when you were in training?
No, everything started by my last mentor. I went to this final training, 6 months of hernia and 6 months of gastrointestinal surgery. Acid reflux problems, belly pain, colonoscopies, endoscopies. But everything started to funnel down to hernias, and I started to enjoy them. And when I got to practice, I realized that a lot of people suffer from them. For all you out there, about 175,000 umbilical hernias are repaired in the United States.
At least, yeah.
So it's impossible to a single surgeon to do all that work. So there is a lot of umbilical hernias out there, a lot of hernias, and many ways and many cool ways to repair them. And that's where my imagination kicks in, all the techniques that we have learned. And it's fantastic for the patients to offer them that.
I always say to my residents when I'm operating that my favorite simple procedure is just a cute little small umbilical hernia. You know, when you go from Outie to Innie, I just think that's the best feeling.
I'm going to give you an Innie.
Yes. Yeah. And it's such a nice cosmetic outcome. I'm not sure I'm saving many lives by fixing the small ones, but it definitely looks better.
And it makes you feel good. It's time, it's
Yeah,
relaxing.
it
It
is.
is.
It is. And so in your practice, how much of your operations are open and how many are laparoscopic versus robotic?
So the open ones are these tiny ones that I write. If I do in my office, I have the opportunity to do ultrasound.
Uh-huh.
So we do this diagnostic test in my office and I'm able to measure it. If it's less than 2 centimeters, a thin patient, we do them open.
Yeah.
Then the vast majority are through robotic surgery. It is the big ones, the ones that we do open technique
Yeah.
because it allows for better exposure, I believe, in or handling of tissues probably, or they
Yeah.
cannot tolerate for some reason the robot.
And for simple umbilical hernias, not the big ones, not the complex ones, but for simple ones, do you do those laparoscopically or
Yes.
robotically?
So again, so when a patient comes to my office, it's very important for the audience to know, hey, what's the size of my hernia? What is the size of it? Or what does it have in what is that hernia holding? Is it holding intestine? Is it holding fat? Or is just the hernia sac? So depending to that, I do my decision. If it's a tiny one, I do it open, especially the patient is slim. But if it's a little bit bigger than 2 centimeters and a little bit heavy patient, I like to offer them robotic.
Yeah,
And they
I
go home
use,
the same day. Both of them, they go home the same day.
yeah, I also use 1.5 for high risk patients and 2 centimeters for low risk patients, kind of my cutoff where you have to do more than just a simple umbilical hernia repair. And so you use ultrasound in your office to just measure the defect? That's a good
Yes,
idea.
it's pretty simple to do it. They don't have to go out of the office to get the ultrasound. We do it right away. I just warn them a little cold jelly is coming
Yeah.
because of the ultrasound and that's it.
Yeah, because what you feel outside may not represent how big the hole is. So as surgeons, we're just interested in the hole, not so much. In fact, today I saw a patient, she was told she has a 4.5, almost 5 centimeter hernia. And the radiologist was measuring how much fat was out, not the actual hole. The hole itself was 1 centimeter. So that changed the whole plan. Completely different for a 1 centimeter hole than a 4 or 5 centimeter hole.
They tend to measure the sac, is what we call it, the sac that bulges out.
Which is totally unnecessary, right?
Yes, it's not necessary. You don't need that. You need to know the size of the hole.
Yeah, I agree. So we have several questions that have been submitted in online, and then a handful that are coming in. So I'll just moderate that for you. One question is, how commonly do you see umbilical hernias as compared to inguinal and incisional hernias?
So inguinal hernias tend to be more common in my practice, and then I follow with the umbilical hernias. Umbilical hernias are definitely more common than incisionals.
Yes, correct. And can you explain why an umbilical hernia is different than an incisional hernia?
So incision, let's say you had your gallbladder removed, and they have to remove that gallbladder out of your body. So they do it by creating an incision and then they remove the gallbladder. They say they remove your appendix, the same thing. So whenever there is a failure of that hole, that the hole that they created to remove the organ, when there is a failure of that hole to close, and you leave an opening creates there, that's an incisional hernia because you have the hernia because they did an incision on you. An umbilical hernia is coming from a virgin belly. They have never caught you there. Nobody has ever done an incision, and it's a hole that comes out at the level of your belly button.
Yeah. And you treat those differently?
Not really. An incisional hernia, actually, yes, I do. Sorry. Yes, I do. An incisional hernia, most of the time I would like to put a prosthetic on it to prevent a recurrence because it's already a damaged tissue. They cut through that tissue. For whatever reason, that tissue failed to come together. So those patients, I would say most of the time, I like to put a reinforcement to prevent a recurrence. In an umbilical hernia, not all the time in my practice, needs the need of a mesh.
Yeah. So, okay, let's discuss that then. What's your algorithm if you see someone with an umbilical hernia, an Outie? Do you agree with me that pretty much an Outie is a hernia unless proven otherwise?
Yeah,
Yeah.
I agree. It's a failure. All of us, we were connected to our mother's womb from an umbilical cord
Yeah.
that was coming from the mother into our belly button.
Yeah.
So when the baby is born, the doctor cuts it, then that cord then falls apart, and then immediately our layers get closed. And a failure of that closure, that's the Outie. That's when
Yeah.
you develop the Outie.
Yeah, exactly. And then here's another question, which is, oops, wrong question, which is specifically, what is the algorithm for someone who says, I was told I have a hernia, I have an Outie, but really it's not bothering me, what we call asymptomatic umbilical hernias.
So it depends. There is a group of physicians out there that state that if it's not bothering you, the umbilical hernia, if you have an Outie, it's not bothering you, had it for a long time, leave it alone. We call it watch and wait.
Yeah.
But the key is this: what are you waiting? So that's what I tell my patient. What are you waiting for it to get incarcerated, or what are you waiting for it to get for you to get pain?
Yeah.
Yeah. So I give them that option, right? There's ones that are willing to wait, it's not bothering me, then it's fine. But some others, I tell them right now, you're young, you are strong, you are healthy. Let's say 10 years down the road, you're gonna be older, and unfortunately, when we get older, we get sicker, right? We don't tolerate surgeries the same way as you were old when you're young. So I tell them, if you want to repair it, I'll say this is the time.
Yeah. And what if they say, you know what, I don't want to have surgery now? Is that considered safe?
Yeah, it's safe. If it's not bothering you,
Yeah.
it's not bothering you, had it for a long time, it's an Outie,
Yeah.
it's not bothering you, you don't want it, I will say you can leave it, let it be.
And which are the dangerous umbilical hernias? Do you have a formula as to which one is more likely to strangulate?
I will say that if it's more than a centimeter, 1.5, that's enough for an inner organ to get in.
Like the intestine. Yeah.
Exactly. Or all of us, we have a layer of fat protecting the inside of our tummy. So that layer of fat can get in there and gets choked, and that hurts. I have seen patients bend from the pain. So that's strangulation too.
Yeah. And I think that, most umbilical hernias, the majority of them are small and they have fat. That's the first organ that goes in there. And often if the fat's stuck in there, there's no space for intestine to get in, So I'm okay if those people are saying, I have no problems, can I just live my life? Sure, go ahead. But then if they have bowel in there, for sure, that's something that I would recommend. There was a great paper that said if your neck to sac ratio or sac to neck ratio is more than 3:1, so the amount of contents is 3 times more than the width of the defect, that's a higher rate of strangulation. But I see that all the time, and I'm not so sure if that's a good formula.
Yeah, that replicates to real life, right? Definitely, if it has intestine in there, yes, get it repaired. And for the audience, you can easily get to know that during the physical exam or with the ultrasound in the office.
Yeah.
Very easy.
Yeah. The next question has to do also with your management. What do you advise your patients when they ask you, like, how fast is it going to grow? Like, is this going to get really big by next year, or is it going to take 10 years?
So there is no rule in time, but there is a rule. If you start to gain weight, your belly muscles are going to they're gonna widen up, and that's gonna make the hole bigger. So, or if you tend to develop constipation, you have problems voiding, peeing, straining during urination. All those things, they're gonna make your hole to enlarge. But if you live a comfortable life, you don't have any of those problems, you are slim, it's pretty hard to tell you, hey, it's gonna grow up a centimeter in the next year. I don't think, and I haven't read anything related to that. How about you?
Yeah, I say it's totally unpredictable. You know, most people, those small hernias, and if they're what I call low risk, so they're fit, they're not coughing, or they don't have constipation, they don't use smoke cigarettes. In California, we have a lot of marijuana smokers. They cough a lot with the marijuana. So if you don't have all those risk factors, you're not obese, then probably that small belly button hernia will stay forever. Some of these people that I watch on Instagram, they've had it for years, and that damn hernia is the same size. But then they get pregnant, some of them, and I see that hernia is now bigger. So you want to talk about pregnancy and hernias? I think that's a good, relevant topic.
So I'll give you guys an example. If you have a balloon, a deflated balloon with no air, the wall is very, very thick. You start to inflate that balloon, the wall of the balloon is going to turn very thin. Same thing happens in pregnancy. Your muscles are thick, but once you get pregnant, start growing that belly, the muscles are going to become very thin.
That's a
and
good
that
analogy.
belly button is going to get wider. It's going to get wider. Okay, it's fine. You can go through your pregnancy with that. The problem is if it gets strangulated. Strangulated means that it went in and start to choke the intestine. That's an emergency. Or that fat that we all have inside, you can choke it. The best time to repair it is after in the second to third trimester. I will say the second trimester is the best time to repair it, but believe me, you don't want to go through that.
Because so do you see that? Have you seen women that are pregnant that are strangulating?
Yes, but only with the fat, not with the intestine. And that's what I tell you, that they hurt because there's so much pressure inside your belly from the baby pushing the fluid, the baby moving, and you have that piece of fat that is you're not able to push it back in. So it gets choke and choke and choke, and they hurt a lot. To the point they cry.
And because most hernias, you would think as the uterus goes up, it kind of covers the hole. So that's why you don't see the intestines, right? Because the intestines are moved away.
The displacement. Yes, you're right.
Yeah.
It could be the displacement. It gets displaced. And let's say, thank God, and let's say everything goes fine and you deliver your baby. So when is the time for you to repair the hernia? We were recently discussing that it's safe to say 3 months after the delivery or 3 months after you finish breastfeeding.
Yeah. That will because of the hormonal changes of the abdominal wall. Yeah, you don't want, I see women, you probably see the same, that they need a C-section and they have a belly button hernia. So it's not uncommon for someone to be pregnant and have like an outie during pregnancy. You can see it through their clothing. It's like a little pressure. And a lot of times it's like a really, really, really small belly button hernia. And once the baby's gone and they're back to their normal abdominal wall, that may not be a clinically relevant hernia. But others, it may be bigger, or it may have bothered them during surgery. During pregnancy. So they say, while I'm having my C-section, can you fix my hernia? What do you say to those people?
I say no.
I know, me too. How do you explain that to them?
So I tell them, hey, you're going to be the hormonal changes that we were talking.
Yeah.
So we have females have the estrogen and progesterone. Progesterone is the one that is up during the pregnancy and is causing the muscle to be laxity, to be very pliable.
Yes.
So you want the hormone down before you repair it.
Yes. I see a lot of people who their gynecologist or their obstetrician, Yeah, well, I'm in there, I'll go fix your hernia, and it's never good. I've never seen one where it worked.
Thank goodness I haven't seen one gynecologist fixing one.
You know, I think the obstetricians try and be nice.
Uh-huh.
But it's the wrong operation. They're doing it from the inside. They just
Oh.
they just sew. They don't take down the actual like preperitoneal fat, you know?
Mm-hmm.
So it's the wrong operation to begin with. They probably use Vicryl, which is the wrong suture to begin with. And it doesn't work. So just leave it alone, see how you do, take care of your baby. Once you're done with breastfeeding, come and see you.
Mm-hmm. Yeah,
That's usually the best.
For the audience, don't choose that option on fixing it.
Yeah, I agree.
At the same time. Mm-hmm.
Okay, there's a question about watchful waiting. It looks like you already answered that. Okay, so now let's say the woman has delivered their baby and they have they have a let's say it's our second baby or third baby. So their belly's already kind of stretched out and they have this belly button hernia. So what do you recommend for them?
So they had the baby. You said you had the baby and the belly, the hernia is asymptomatic or symptomatic?
Let's make it easy. It bothers them.
Okay. So if it's bothering you and you already had the baby, the time is wait 3 months after you have stopped breastfeeding.
Yeah.
And it's because, again, going back, the hormone will go down after you stop breastfeeding. And also your belly is returning to normal.
Yes.
You may get this, your surgeon may get the wrong perception. Oh, like you say, oh, it's wider than I thought.
Yes.
Or the tissue is too pliant because you're doing it too early. If you wait a little longer, the tissue is going to be stronger and it will have the more natural shape. So
yes.
You won't be confusing the judgment of your surgeon.
And it will hold the suture better.
Yes, absolutely. A stronger tissue.
So I made a comment about Vicryl suture. So one of the audience members said, why is Vicryl the wrong suture for an umbilical hernia repair?
Oh, because it's going to dissolve. It's going to absorb. It's going to fade away. So you want something that could stay. That's for one. Vicryl also, if you put it under the microscope, is made of multiple threads. So those threads can get if a contamination happens, because sometimes they happen,
like a C-section, during a C-section, yeah.
Especially during a C-section, some bacteria can get into that thread. You want a suture that is permanent, and a suture that is we call it a monosuture, a single suture with no braiding. So
yeah,
that way, you're making it harder on the bacteria. Yeah,
Vicryl suture or Dexon, depending on the company, it technically loses its strength in about 3 weeks as it starts absorbing. So we usually don't use that as a definitive hernia repair. We can use it for other things like skin and soft tissue where you don't need that tensile strength, but we don't usually use it for that. Here's a question I get asked a lot. Let me show you the question. It says, I had laparoscopic surgery, and ever since then, I've had a diastasis where the abdominal muscles separate. Could the insufflation from laparoscopy cause my diastasis? Do you hear that?
No, actually, first time
maybe it's just my patients.
California patients. I don't think so, because the CO2 during the surgery absorbs. It's not done for a prolonged time. I don't know how long it will take to remove the fibroids, but maybe an hour or two, not that much. But what I'm worried during those cases, I know this is fibroids, endometriosis is when you can create seeding, like little microscopic.
Oh, you think
implants.
so? From endometriosis, you can seed it from laparoscopy?
I had a patient once that she had a hernia repair in the past with mesh, and I went in, and between the hernia and the mesh, she had endometriosis.
Wow.
From the previous surgery, yes.
No kidding, between the hernia and the mesh. I've
Yeah.
never seen that. And I see
Mhm.
a lot of endometriosis. I work with a lot of these gynecologists who just specialize in it.
Mhm.
And I help them for any GI involvement of the endometriosis. Plus, many of them have chronic pelvic pain, and sometimes it's a hernia, not the endometriosis that's causing the
Mhm.
pelvic pain.
The pain,
Wow.
yes.
So abdominal wall between the hernia and the mesh, that's a difficult one. How did you figure that one out?
Because I was the patient had a hernia recurrence, so the mesh had already it was folded or
Uh-huh.
it was folded on one side. So when I was explanting and removing the mesh, I'm
Yeah.
like, what is this chocolate appearance? And
Wow.
I thought that it was the because we put a little bit of oil in the instruments of the robot. So
Okay.
I kept looking like, hey guys, don't put too much. Look what you're doing. And then I realized I
Oh,
kept seeing more and more. And I'm let's send it to the pathologist. And boom,
that's,
endometriosis.
and then
Mhm.
did their pain go away? Was that a reason
Yeah,
for their pain?
very happy lady.
Yeah. That's pretty
Very
cool. I
happy.
mean, good
Hmm.
that you help the patient too, but
Hmm.
very interesting.
I'm very lucky we found it.
But a lot of
Mhm.
patients that have told me, oh, I didn't have this hernia or I didn't have this abdominal like diastasis
What do
until
you
I had
think?
my laparoscopic surgery for something
What do you
else.
think?
I
What
don't
do you
think it's
tell them?
from that. I think they just
Mhm.
noticed it for whatever reason because the pressure that we insufflate is maximum 15 millimeters of mercury.
Mhm.
And that can't be, I mean, a cough is much more pressure than that,
Mhm.
getting out of bed probably causes just that much pressure. So it
Mhm.
can't be from the insufflation. But every once in a while, I wonder if, for example, you know how patients, when they wake up from surgery, some of them wake up kind of violently and they do a lot of
Mhm.
bucking
Uh-huh.
before the tube is taken out. I wonder if
Yes.
that pressure,
Probably a hernia, maybe not to separate the muscles,
yeah, I agree.
spread them apart.
I agree. Yeah.
Mhm. Maybe they
Um,
just notice it more when after their surgery.
yeah. The next question is, if you have an umbilical hernia, what are the symptoms that require going to the hospital?
I will say if it hurts you at the belly button level, hurts
Yeah.
you a lot, and you see that the skin in that area has turned red
Oh, yeah.
and they're warm to it's warm to the touch in that area,
Yeah.
and you are feeling nausea and you haven't gone to the bathroom to do number two, then you should go.
Yeah. So,
Mhm.
yeah, I would say more than 4 to 6 hours of constant pain. Definitely that's a sign of an emergency. Any
Mhm.
redness or like super, super painful, belly button, uh, I would go to the emergency room and not wait. Because what are the consequences if they wait? Do you want to explain what
Yeah,
could
so
happen?
if you wait, two things can be there, right? One could be the bowel, and
Yeah.
if the bowel is choking there and it's hurting you more than 6 hours, that means that more than 6 hours, the hernia has been choking your intestine. So your intestine
Yeah.
most likely will die.
Yeah.
And if it dies, then that's a whole different type of surgery that you will need. You will need likely they will have to open you. They will. It requires a skilled surgeon to do it through laparoscopy. Get
Yes.
in and remove that dead segment of intestine, reconnect it, and fix your hernia at the same time.
Do you do a lot of emergencies and on-call work?
I still take a ER call. I still do, and
Mm-hmm.
I enjoy it. I
Yeah.
enjoy it
It's
because
because you're young.
you. I still have the energy.
Yeah.
So I like it because you can actually you help that patient in the moment, like they are
True.
desperate for the help,
Yeah.
and I still I get that. It makes you feel very good
Yeah.
from
My
me.
first job was that. My first job was I was part of the laparoscopic surgery group,
Mhm.
but we took call for everything that we called it non-trauma surgery.
Mhm.
So there was a trauma team and there was a non-trauma. So if you came in and because you were stabbed, it went to trauma. Everyone else came to us: dead bowel obstructions, necrotizing fasciitis, gallbladders, appendix. I liked it because I call it my box of chocolates, you never knew
They
what
give
would
you
come in that
template.
day, and took care of it,
Mhm.
and it was really great, like a way to just hone your skills and be like a great
Mhm.
surgeon.
Yeah, you come
Yeah.
the next morning and you are like, how do you feel? They tell, I feel great. Thank you.
Yeah.
Thank you. I feel better. They're eating.
Yeah.
Mhm.
Yeah. I mean, I love hernias, but I just don't have the energy to do that much call. Like I used to do so much in-house call.
Mhm.
But it was very, very fun and satisfying because you did everything. Whatever came to the door, you handled. It was really great.
Mhm. Oh no, they gave me the option to stay in the hospital. They say, hey, stay in the hospital 24 hours. I'm like, no, if I take the call, I'm taking it from home, from my home.
Oh yeah, I was not given that
So
option.
no, I'm like, I want to sleep in my own bed.
Yeah, it was we operated between 10 p.m. and 4 a.m. That was like it was at the county, LA County, and it was very rigorous and fun at the same time.
And I
Yeah,
bet a lot of patient flow, a lot of
a
people
lot,
consulting. Yes, the
a
county
lot.
hospital.
Yeah, it was
Mhm.
great. Very grateful patients, wide variety. I even had a patient with the plague. Can you believe that?
The plague.
The plague.
Wow.
Yeah. Yeah, we
Then
had
you
one. If you read LA Times, Los Angeles
Mhm.
Times, they reported that there was a plague in LA. That was my patient. Yeah, pretty
You
crazy.
notice it? You saw it?
I had
That-
no idea. I had no idea. I was on call and I got a phone call from the Los Angeles County like Department of Health or something. And they said, "Are you Dr. Tofi?" I said, "Yes." They said, "Do you have such and such patient?" "Yes." He said, "We're calling because her cultures grew out Yersinia pestis."
Mm,
And I'm like,
mm.
"What's Yersinia pestis?" I said, that name sounds very familiar, but what is Yersinia pestis?" And she said, "That would be the plague." Yeah, yeah.
Shower, wash your hands, wash your clothes.
It's a great story. I'll share it with you in details later, but uh it was a poor family that couldn't afford meat and protein. And so the husband would go to the local park and kill rabbits there's like a rabbit area
Mhm.
that was just and then he would serve rabbit meat, and those rabbits had the Yersinia pestis. So he got his wife sick, and Levaquin, ciprofloxacin and Levaquin is the treatment. If you ever have anyone with the plague, it's Levaquin. Yeah, we gave her Levaquin just because we didn't know why she was so septic, but it worked. We saved her life, but we didn't know
Three
until
rabbits.
2 days
Not many
later.
three rabbits in Houston.
Rabbits, squirrels, and um uh what do you call bats? Rabbits, squirrels, and bats get it.
Squirrels, we have a lot.
Yeah, so do we.
Mhm.
And of course, like rats. But
Yeah.
they lived in a rat infested area of town, and they tested the rats, and there was no rats that had it. But then they figured out he was killing rabbits to feed his family.
Interesting guy, huh?
Yeah, interesting story. In fact, when they came to the way they figured it out is this is not related to hernias in any way, but it's a good story. When they kept going to his home to try and figure out where this Yersinia was. And very lovely family, very poor. They offered him or her some pate when the health department came to visit.
Mhm.
And she's like, "No, thank you. What is that?" And he said, "It's rabbit meat." And they're like, "Rabbit
Oh,
meat? Huh, where did you get this rabbit meat?" Then the man got really nervous, and he said, "The local grocery store." And they knew that you can't buy rabbit meat at the local grocery store. So that's when the story came. And then he admitted that it was his like little delicacy. He would make pate. Uh, so it wasn't cooked. And it was from that rabbit meat. Yeah, they tested it, it was positive. Yeah. Interesting story. Yeah, he felt really bad. He almost killed his wife, but It was obviously not intentional. He was trying to help his family.
Give him some protein.
Give him protein, I know. Okay, back to hernias. For umbilical hernias, what are the predisposing factors?
So I would say anything that increases the pressure inside your tummy.
Good. Yeah. Agreed.
Will give you a belly button hernia. Anything that increases, like pregnancy increases your pressure, coughing, straining for bowel movements,
yes,
straining for urination.
Because of an enlarged prostate, yeah.
Enlarged prostate. And interestingly, this is I found this very interesting. It's common that patients think, oh, when I'm in the gym lifting, right?
Yeah.
Actually, that one doesn't cause that much pressure inside your tummy,
right?
Because you're using your other muscles.
Yeah. In fact, how many bodybuilders that need belly button hernia repairs? Almost never. Yeah. Or athletes. Yeah, they don't have it.
Yes.
Although during the Olympics, I did notice some belly button hernias, but they were really small.
Little Outies.
Little Outies. Yeah. A couple of track stars had it. Go on my Instagram. I posted the track stars. Okay, great question. Coming in live. Can you also talk about diastasis recti? When are they dangerous and when should they be repaired? What about the combination of a belly button hernia and diastasis recti? How are they handled when occurring together? That's a great question.
So us as hernia surgeons, as especially laparoscopic surgeons, we have the advantage that we can fix a belly button and the rectus diastasis, the muscle separation, at once. And we can achieve that repair through the same tiny incisions, okay? As opposed to plastic surgeons that they have to do a huge cut at the level of your bikini line and do a huge flat, lift up your skin and fatty tissue to fix your belly button and fix your muscle separation all the way up to your breastbone.
That's a tummy tuck.
Yes, but we're able to do it through tiny incisions. We can definitely fix that. I will say dangerous for diastasis when it becomes too wide. When it becomes too wide, then your abdominal muscles and your back muscles are not working properly.
Yeah, core.
You don't have what we call it the core, right? The core muscle. So all of us, we have an abdominal wall. This wall is supposed to be holding things in place, and it's not functional. It's not proper. It's not doing its proper job when the muscles are separated, and especially if you don't exercise your back muscles. So where is the core getting their strength? It's not. I read a couple of papers that even patients that have problems like COPD, difficulty breathing, and diastasis, you're fixing their diastasis, and they tend to breathe better.
Oh, well, the diaphragm is part of your core.
Yeah. You don't have your accessory muscles for breathing.
So, what operation do you offer them?
So I do. If they don't have a belly, if they do not have an umbilical hernia, I do their incisions at the level of the bikini, at the bikini line, and I fix their muscle separation. If they have a belly button hernia, I do 2 incisions on their upper belly. And then I do those 2 incisions in the upper belly, tiny ones, and I create a space around the muscle separation. And then I move again to the bikini line and I fix it from below, from the bottoms up, from the belly button up. So they end up with 2 more skin incisions. If there is no hernia, they get 3 incisions at the bikini line. If they have a hernia, I fix them with 5 tiny incisions, 2 in the upper belly to create the space, and then I move down in between the legs.
Okay, let me ask you this. Okay, so we're talking about laparoscopic or robotic plication of the diastasis with or without belly button hernia repair. So what we're talking about is people who have umbilical hernias, they have a variety of options for repair. But if the umbilical hernia is within the diastasis, so it's everything that we're talking about is in the middle of the abdomen. But if the hole is floating in a thinned out part of the abdominal wall from a diastasis, it could be in men or women, then closing that hole has a higher failure rate because it's very thinned.
Exactly.
So, right? So
yeah,
you're proposing, don't do that. Let's fix the whole thinned out part,
exactly.
and that will support the belly button hernia repair. Or just,
Exactly.
okay. So you're doing
I don't
those
think it's right to just
anterior.
fix I don't think it's right just to fix the belly button
Yeah,
and then you patch it with a
yeah,
mesh. Then you
yeah.
have created a very strong area there. But the other rest of your belly, the diastasis is an area of weakness. So you can,
Yeah.
the hernia can come back there. So
So the traditional repair is a tummy tuck. It's a very large lower abdominal kind of incision, and then you clear all the fat and skin off of the muscle all the way to the chest wall, find the widening, tighten the widening, and then reposition the belly button with and take out extra skin. That's a typical tummy tuck. What you're saying is you're putting three trocars in the lower abdomen where it's not visible. And you're doing the same procedure in terms of removing the skin and soft tissue, the fat off of the muscle, demonstrating the weakness, and then you're closing it. So that's like Ripa, Lira, Scola, all these Milos, all these different terms for it. Do you use mesh for that?
Not if I'm doing it over this, not if I'm in the adipose tissue and muscle.
Yeah.
If I'm doing those techniques, Scola or Repa, I won't. But if I do for the audience, there's many ways to do this.
Yeah, there's a lot. There's like 5 different terms for it. Milos,
So
Emilos, Scola, Ripa, Lira. It depends on which surgeon described
for
it.
example, today I did a patient. She had a wider tummy. All right, she's not skinny, not thin, and so she has a wide tummy. So I did, instead of doing the 3 incisions at the bikini, I did them on her side. And then the robot has less chances of colliding. It's easier. And on that patient, from the inside, I fix the belly button and I just go up all the way to the xiphoid process, all the way to the rib cage.
Yeah.
What we call it plication, bringing it together.
Yeah.
It's like whenever you have an accordion.
Good analogy. You're very good with your analogies. Right? I like that.
And then you bring it together. And nowadays, in a group that you and I are, we call it the International Hernia Collaboration.
Yes.
They post a very nice way to do these stitches so the patients don't see the ridge on the outside.
Yeah.
So that's, I'm doing that even more nowadays. So,
and then you don't reposition the belly button, you just take it off and then push it back, sew it back down.
And sew it back together.
Yeah.
Give them the Innie again.
Yeah.
Do you reposition belly button?
Well, so here's my story. So I started doing these robotically posterior plication, not anterior plication.
Posterior plication, huh?
Posterior, so extraperitoneal posterior plication. So instead of sewing it like a plastic surgeon would do, I would do it from the inside. And they did very well. However, what I then looked at my data to see how the patients did. First of all, you're right. They get like this ridge, but that ridge lasts about 3 months and then it goes away. For most people, they don't see the ridge. But I was not using mesh. And I would do 2 layers of closure. And if there was a hernia, I would fix it as part of the hernia. But what I found was, especially if I did it in men, they have this kind of like very rounded belly. They fell apart. A good proportion of them fell apart. The hernia didn't though. So what I learned was, if I'm doing the posterior plication to sew that muscle together in order to give a better hernia repair, to kind of support the hernia repair, that worked very well. But if I did it purely for cosmetic purposes to give them a flatter belly, it wasn't good because a good proportion of them tore apart.
But you were not using mesh.
I was not using mesh, correct. So what I learned was, if the goal is to give application and not just fix the hernia, I should be using mesh, especially in these very rounded male abdomens. These were not obese men necessarily. It's just they got that kind of rounded look. So I did more research on it. The anterior plication is just a better repair. It's stronger. Plenty of data by the plastic surgeons showing that you can do a non-mesh anterior plication even for really wide hernias, and they do very well. My issue with anterior, and I'd like to see what your opinion is, unlike the plastic surgeons, we are not releasing all the skin and fat. And so and that's still attached to the
muscle.
That's still attached to the muscle. And therefore, my concern is that cosmetically, that skin and soft tissue is going to look ugly because it's being pulled tighter. And so you get like this extra skin in the middle. Tell me more about that.
Exactly. And today, so I had clinic in this
Remember,
morning.
I'm in Beverly Hills. Remember my concerns.
Mine is Galveston. Okay.
Yes.
Not that fancy.
Yeah.
So I had a lady today that exactly what you're saying. And she told me like, but what is this now? And it was the floppy skin.
Yes.
And I'm like, yeah, that's fat. That's fat that you have. And you can keep losing weight, burning the fat, but you will that floppy tissue will still be there.
Yeah.
And unfortunately, that's one of the pitfalls, I would say, or the but it's a very good repair.
So I offer that for people that have a little bit more skin and fat because you can't tell as much. But if they're very thin, I still say tummy tuck is better, or because they're not going to be happy with the skin part of it.
How about if you do it from the inside with mesh on those skinny ones?
Yes, so I offer that to them. So some of them don't want mesh, but yes, if they're okay with mesh, I could do the posterior repair, add the mesh, and that ridge will go away. It just kind of flattens out and not an issue. But I always tell them that, but the anterior repair is better repair. But some of them are not good candidates for tummy tuck because they have no extra skin.
That's right.
Here's another question. Can a TEP repair, so this is a laparoscopic inguinal hernia repair that's done extraperitoneally. Can a TEP repair for an inguinal hernia be safely done in a patient with a known umbilical hernia and diastasis? In other words, can the it's not blind, by the way, but retromuscular dissection be safely done without enlarging the diastasis? Yeah. Not an issue at all. Let's see. Oh, here's a question. We kind of answered it, but
it's a pre-medical question.
Oh, I know. My viewers are so smart. They ask really good questions.
Yeah, they read a lot.
Which umbilical hernia does not require mesh to fix?
I will say if you are thin patient and your hernia, in my opinion, less than 2 centimeters.
Yeah.
I wouldn't use mesh.
Yeah.
So
so here's how I tell it. So the studies say 1 centimeter, but I think that's just a bad study. In other words, scientifically speaking, if you compare mesh or no mesh for anything over 1 centimeter, the p-value, right, the significant value, drops out at 1 centimeter. But the difference, like clinically, is so different. It's like barely anything between mesh and no mesh for 0, 1 centimeter, 1.5 centimeter, maybe even 2 centimeter hernias. So I do what you do. Exactly. So for low risk patients, I'm willing to do a tissue repair without mesh up to 2 centimeters wide. For a higher risk patient, I get ANSI after 1.5 centimeters.
Okay.
Yeah.
And those ones you do mesh.
Yeah.
And do you do those through laparoscopy, or you will still do it open?
For mesh, I would do laparoscopic.
Mm-hmm.
Yeah, I don't like to do open mesh repairs for
Open mesh.
umbilicals.
Mm-hmm.
Yeah, there's no good benefit to it. Yeah. Okay, here's another question. It says, what is your preferred technique to fix umbilical hernias?
So it depends on the size. So if the size, the same thing that we were just talking, small, less than 2 centimeters thin, my preferred technique is to do an incision inside your belly button.
Inside, okay.
Like in the Outie, I cut it, and I typically mark the patient. I tell them, hey, maybe like half an inch is going to be outside your belly button.
Yes.
But you can barely see the scar. So that is my preferred technique. Same as you, I love that procedure. I enjoy it so much.
So cute, right? Yeah.
And and then the other ones, I fix them robotically with 3 incisions on your side.
Yeah. Yeah, and I agree with you. Same. Laparoscopic or robotic, and I almost make it like a challenge, because I always operate with residents and fellows. Like how perfectly cosmetic can we get? It's like my little plastic surgeon in me comes out when I do belly button hernia. It's like, how perfect can I make that belly button look? I'll share with you a trick. So when you do the Innie part, don't bring it straight down. Go maybe like 5 to 7 millimeters south.
Oh, okay.
Yeah, because if you go straight down and when they stand, the belly button hooks upwards. But if you go a little bit south, when they stand, the belly button goes exactly backwards. Because when
keep going with the incision out of the belly button down.
No, the incision's fine. Your incision's fine. But sometimes you have to take the stalk of the belly button skin and sew it down on the fascia. So instead of sewing it straight down,
I hear you. Yes.
Sew it a little bit further towards the feet, like maybe 5 to 7 millimeters.
Okay.
That way, when they're all healed, and they're standing and looking at you, the belly button stalk is straight back. Otherwise, it tends to tent up.
To go up. Okay.
That's
I'll try it.
That's my little trick. You heard it here first. Another question: how do you decide when to do open or laparoscopic for diastasis repair, and how do you decide when to use mesh?
So for diastasis, I don't do open.
Yeah.
For laparoscopy, I do a laparoscopic, and then when to use mesh. If I'm fixing it from inside out, from the inside,
posterior,
and posteriorly, I always use mesh.
Yeah.
And on the outside, when I'm fixing it from the outside, I don't use mesh because I'm worried that people are going to develop fluid there, and that fluid is not going to. Yeah. That fluid is not going to allow the mesh to incorporate. Some others say that it doesn't matter, that the body will incorporate into the mesh very easy.
Yeah.
And I'm just a little bit more careful.
Yeah, I would say my answer is, for open, you have to have a lot of excess skin to be worth it to do an open abdominoplasty, because that's part of the tummy tuck. And anyone with a really wide diastasis, so I would say 4 or 5 centimeters or great or wider, probably better to do it open, like by a plastic surgeon, board certified plastic surgeon. The laparoscopic or robotic, it's a better repair anteriorly than posteriorly, and therefore if I do it posteriorly, I have to use mesh. However, it's really hard for me to find the right person to do it anteriorly because of this issue with the skin. So it depends on how important the cosmetic outcome is for the patient and how thin they are, I think, for me. So I struggle with that. I haven't come up with a perfect solution yet. I don't know.
I like you have opened up my eyes in regards that floppy skin that develops at the end. That's true.
Yeah. Yeah, it's because you're
true.
not releasing the skin laterally and you're not taking out any extra skin in the middle, but so you're bringing the muscle together, and the muscle is attached to the skin, especially laterally. So it's I've seen people who've had it done and it just doesn't look right. You know, no amount of massage is going to make that skin move off of the muscle.
No matter how much collagen they buy and apply.
Yeah, that's not going to work. Yeah, it's a problem. Or, you know, they do this like skin burning. Have you seen that?
The
Vaser.
Cold or laser? No.
It's called vaser lipo, or there's some other terms where they go behind the skin and they burn the dermis and it tightens the skin.
Oh, wow.
Yeah, they do a lot of weird things. I guess that may work, but I don't know. Plastic surgeons have a lot of tools
and tricks.
Here's another smart question. I did not come up with any of these, by the way. If the belly button is such a weak spot, why do surgeons use it as a trocar port site for laparoscopic surgery?
I would say because it is, and that's a very good question, right?
Yeah.
And you're right, it's a weak spot, yes. And I would believe that we use it, one, because we are in the middle of the belly. We can have a panoramic view. We can go up, we can go down, left, right.
Yeah.
And the third is that we can hide that incision inside your belly button.
Yeah, I would say for bariatric surgery, many surgeons do not go through the belly button because the patient is already obese, and therefore they have a higher risk of an incisional hernia from that trocar site. So they often go off midline. Did you get bariatric training too as part of your?
Yeah, we did bariatrics.
Did you go off midline with your periumbilical?
And even the removal of the stomach is done on the
through the rectus,
to the side of the midline. Yes.
Yeah. Because it saves. It's a better
less chance of hernias.
Yeah. So that all makes sense. Yeah. So
that's a good question.
It's a great question, right? Yeah. Okay. So Gabriel, what kind of practice do you have if someone wants to see you? You know, I get a lot of patients from Texas. And you're right, there are very few of you in Texas. They're like, it's like almost there's like you and maybe one other person that I can think of that does hernias for a living.
I know a guy in MD Anderson.
Yeah.
And then in the medical center, which is
but you can't see him. That's David Santos. He was one of our guests. You can't see him unless you have cancer.
It's hard. Yes, hard to get them. And in the medical center, the largest medical center in the world, most of the surgeons, nothing bad, but they do open. Yeah. So how can you see me? I have, you can go to my webpage, GabrielArevalo.com. It's my name, GabrielArevalo.com. And just hit the contact us, send me your comment, your name, and my medical assistant will reach out to you via email or via phone. If you call our office, most of the time we don't answer. It's bad. The telephone system is not the best, but if you leave a voice message, we do listen to the voice message every single afternoon.
Okay. And what if they're outside of Texas?
They can, for example, I saw a patient today from out of state. We do a telephone visit. Yeah. So it can be telemedicine, but for that one they are billed. But if it's just a telephone a quick phone call for me to introduce to the patient or the patient to introduce to me, vice versa, that is at no charge. We can establish that. That's great. We can establish a relationship, and if you like what you listen, or have a quick, because sometimes imagine they're gonna travel from out of state to see me, and they will be like, hey, I have, I don't know, something different. Yeah. That they think is a hernia, but it's truly not a hernia. Yeah. Then I save them that trip. Okay, so if they're out of, because we can't practice out of our own state. So if you have someone, let's say in Chicago, that wants to see you, you're willing to speak with them on the phone to see if it's appropriate for them to fly in to see you, and then they'll fly in to see you. That's very nice. Exactly. Exactly. Of course, before this phone call, they have run their insurance. My medical assistant have run their insurance. And
Yeah. Okay. Well,
but-
that's very nice of you.
yes. Again,
thank you.
Gabriel@arevalo.com. Very easy to get a hold of me.
And you're also on Facebook, Dr.
Yes,
Arevalo.
Facebook, yeah, and Instagram, same thing, Dr. Gabriel Arevalo.
Yeah, you have good videos. I've watched your videos. Very good.
A little bit of me and a little bit about hernias.
Yes. Well, that's it for us, everyone. That's the end of Hernia Talk Live, our weekly Q&A with excellent colleagues of mine that I share with you. Dr. Gabriel Arevalo did a great job of donating some of his time, talk about umbilical hernias. Thank you, everyone, for following me on Facebook at Dr. Tofi. Do go to my YouTube channel, subscribe. Every week we'll post the that week's session, and you can watch it while you're brushing your teeth or driving. You can find me at HerniaTalk on YouTube. And again, Gabriel, thank you so much. I really
Thank you
appreciate
for the
it.
invitation.
Thank you, and hope you have a good night.
Thank you.
Thanks,
Bye-bye.
everyone. Bye-bye.